students, welcome back. We are now moving on to chapter 8, which is going to help us learn all about joints. The proper anatomical term for a joint is articulation. So if we take that word sort of apart, articulate means to put together. So for instance, if somebody is articulate, it means they're good at putting their words and sentences together. So an articulation is where two bones come together, and that's what we would normally call, or in lay terms call, joint. So when we think of joints, we often think of the ones that are in our long bones. So for instance, the elbow joint, the knee joint, the ankle joint, the wrist joint. But there are many different kinds. And really what a joint is a point where two bones come together. So there are hundreds of joints in the body. Wherever two separate bones come together is technically a joint. Now the different types of joints are going to allow more or less movement depending on the type. So let's have a look here. If you have something called TMJ, that's a condition where you maybe grind your teeth, or perhaps you have an inflammation of this joint right here. That's called the temporomandibular joint. So that's where we get the phrase TMJ. And so that joint is named for the point of articulation between this part of the temporal bone here and this part of the mandible. And that's the typical format you'll see with joints. They're often named for the two bones that are coming together. So you have that joint. That's a freely movable joint. But right here, in the picture on the right, let me change my pen here. Picture on the right, this is also a joint. This is where the clavicle articulates with the manubrium of the sternum. So that joint is called the sternoclavicular joint. And that's less movable, right? When you think of joints, you're probably not thinking about where your collarbone articulates with your sternum. And it is definitely a joint because it's a point where two bones come together. And just one last example would be this joint here, called the sacroiliac joint. And that's where the sacrum here articulates with the ilium of the os coxa here. And you wouldn't necessarily think of that as a joint either. It's not freely movable like the knee is, but it's a point where two bones come together, so nonetheless it's classified as a joint. So as I mentioned, a joint is anywhere where two bones come together or articulate. Some of them allow for movement, some of them do not. we're going to go through some examples of the movable ones and non-movable ones here in a minute. What's holding the bones together is going to be cartilage, fluid, and or dense connective tissue. And so bones can't just kind of sit next to each other and hope that they don't come apart. There's got to be some sort of other tissue holding those two bones together. So the way that we classify joints is functionally, by the amount of movement that they allow. So based on how they function. So there are immovable or slightly movable joints, immovable or slightly movable, and these tend to be in the axial skeleton. And if you think about it, that makes sense because your axis is your core of your body, where it's going to be stabilizing or supporting the majority of your weight. So there you don't want to have two freely movable joints, right? You need to have that stability. But everywhere where bones come together, you don't want those bones to be fused together in one bone either. You do want slight mobility there. And then the other way we classify joints is those that are freely movable. And those are more common in the appendicular skeleton, in your appendages, your arms, legs, hands, and feet, because we do want free movement there. Those are our appendages of mobility. That's how we get around. That's how we grasp things. So in that part of the skeleton, it makes sense to have those joints freely movable. So the first type of joint I'd like to cover is a synarthrosis. So let me just break down this word for you first. Let me get a different color here. So SYN means fused, and then the ARTHR means joint. The end of this term is plural. So if you're just talking about one of this type of joint, then it would be written like this, Synarthrosis. But often in Latin, when we want to make a term that ends in IS into a plural form, we change that IS to ES. So synarthroses are immovable joints. So these are joints where bones have formed in the fetus independently, but have grown together. So that's what the fused part of that means. So in the fetus, these bones will form separately and be separate bones, but over time, those bones fuse together. And the characteristics of synarthroses, or one of the characteristics of synarthroses, is that the bones are interlocked and bound together or held together by dense connective tissue. So the bones have grown into one another, but also they are being held together by not just dense connective tissue, but more specifically, let me get a better pen here, more specifically the periosteum. Remember that periosteum that surrounds all bones? That's made of dense connective tissue. So the periosteum of both of those bones weaves together to help hold those bones together. So I'm going to show you, I'll just go over these. So some examples of where we would find synarthroses would be what we call the sutures of the skull. Remember the lines that you see on the skull? Those are called suture lines. And that's evidence that bones have formed independently but have grown together. Remember, suture means stitch. So it almost appears that there's a stitch there, or a line where those bones are held together, and that's where those bones have actually grown together. A gomphosis is where a tooth sits in the alveolar fossa, what we might call the socket. But you guys are still learning that term. Where a tooth sits in the alveolar fossa, that is a joint. Technically, it's not movable, or shouldn't be, but teeth are derived from bone, and the maxilla and the mandible are also made of bone. So technically that's a joint. There's also what we call a synchondrosis, and remember, chond refers to, you guys can say it with me, cartilage, right? So this is where hyaline cartilage is holding the bone together. Or another way to say that is hyaline cartilage separates the ends of the bones of the joint. So if you go back to endochondral ossification, remember that the epiphysis in a growing individual is separate from the diaphysis. It's separated from the diaphysis by that growth plate, or that metaphyseal plate, or epiphyseal plate. You can use any term you like, but there is a thick piece of cartilage that is anchoring the epiphysis to the diaphysis. So that's technically a joint because it's where two bones come together. And then lastly, another example is what we call a synostosis. Again, syn means fused, and ost means bone. So this is where two bones fuse together to form one bone. So that means, in most cases, this is where bones are developing independent of one another during fetal development. But as the individual grows and continues to develop, those bones fuse to one another. So let me give you an example here. This image was taken, or these images were taken from the Complete Anatomy app. So this entire bone right here that you see, this entire thing is called the os coxa, but it has three different parts because it's formed, the three different parts form independently and then eventually fuse together. So up here, this is the ilium of the os coxa. This is the pubis in green here, and this is the ischium. That is the bone that you might refer to as your butt bone or your sit bone. So those three separate bones form independently and then ultimately fuse together to create one os coxa. So this is a really good example of a synostosis. Show you? Oh no. The next type of joint I'd like to discuss with you is an amphiarthrosis. And amphi means kind of somewhere in the middle. Think of an amphibian. Where does an amphibian live? It doesn't live entirely on land, and it doesn't live entirely in the water. It's kind of somewhere in between. So the way I think of an amphiarthrosis is that it's somewhere in between freely movable and an unmovable joint. So that's how amphiarthroses are classified. They're slightly movable, and their bones are a little bit further apart than you might see in a synarthrosis. And the bones are going to be connected by either cartilage or ligaments. So I've got in the next slide a picture for you that shows you two examples of amphiarthroses. One that's called a syndesmosis and one that's called a symphysis. So in a syndesmosis, the bones are anchored together via ligaments, like many bones are, but in an amphiarthrosis, they're only going to allow for slight movement. And then a symphysis, where bones are connected using a fibrocartilage pad. So let's look at this picture right here. So the picture on the left is showing you a right tibia and a fibula. And technically, these two bones create a joint, right? Because this is where they're coming together. But this is not a freely movable joint. It's only a slightly movable joint. And right here in the middle, I'll highlight it in yellow, would be the ligaments that are holding those two bones together. So that by definition is a syndesmosis. I don't know, I hope you can see that yellow where I drew in there. You might see it written or called an interosseous membrane, like you see right here. That's just another term for the ligaments that hold or anchor those two bones together. And then over on the right, this, oops, let me get out of highlighter mode here. This structure right here is a fibrocartilage pad. And that fibrocartilage pad is anchoring, at least anteriorly, this os coxa to this os coxa. In fact, there's a specific name for that symphysis. It's called the pubic symphysis. This is something that you need to identify in lab. And one interesting thing about this pubic symphysis is that in women who are pregnant, circulating hormones are going to loosen up the collagen fibers here. So imagine this being made of a bunch of collagen fibers. Circulating hormones, one in particular called relaxin, is going to relax those cartilage those collagen fibers and allow for this pelvic inlet right here to widen a little bit. So essentially, this pubic symphysis is going to expand a little bit, become a little bit wider, so that this area here, this pubic inlet or pelvic inlet, becomes a little bit wider to allow for, this is going to be a bad baby head, but allow for that baby's head to pass through and out during labor. So sometimes these collagen fibers don't go back to their original shape. So often you might hear women say, well, my hips got bigger after my first child. Well, that might seem like the case. They didn't necessarily get bigger, but that distance from iliac crest, right, I'll just abbreviate it, iliac crest right here to iliac crest right here might be a little bit wider because those collagen fibers here have been stretched out a little bit and they haven't or won't go back to their original resting shape. So that's kind of a neat side bit. Oops. Now we're going to move on to diarthroses. And diarthroses are also known as synovial joints or freely moving joints. We lost some of that behind the picture there. Freely moving joints. So this is what we're going to focus on now for the remainder of the lecture, these freely moving joints. And these freely moving joints, these synovial joints, all have some things in common. They're all going to have a capsule, a fibrous connective tissue or a dense connective tissue capsule around them. I'll show you this in the next picture. They're all going to have what we call a synovial membrane. Inside of that articular capsule is going to be filled with synovial fluid, and it's going to be innervated by blood vessels and nerves. So these are the joints that we normally think of when somebody says the term joint. These are found at the ends of long bones in your upper and lower limbs. So the phalanges, the hips, the elbow, the wrist, the ankle, the shoulder, these are all freely movable joints. Let's have a look at a larger picture of a synovial joint. And over on the left, you are seeing just a really basic drawing of the joint without the musculature and subcutaneous tissue. And then over on the right, you see everything kind of all at once. So this is a sagittal section, meaning that you're looking at it like if you were to take a piece of pipe and cut down the center of that pipe and separate the pipe into two equal halves. So this would be the anterior side, and this would be posterior right here. Although that's not very well shown in this picture. It's better shown over here. But the point is that this picture shows you some of the key features of a synovial joint. So first up would be the articular capsule, which is that beige kind of striated structure that you see right here. And that encompasses the entire joint. It completely surrounds the entire joint. I'll give you a tip. If you go to the Complete Anatomy app and you show the skeleton but then select or add layers of connective tissue, you'll be able to see that articular capsule. So that articular capsule is made of dense connective tissue and it encompasses the entire joint. Well, look up here. Surrounding that joint is periosteum. So essentially what happens is that periosteum, I'm going to change pens here, that periosteum becomes the articular capsule, and that articular capsule weaves directly into the periosteum of the next bone. So that makes a really tight connection. It's like woven fibers in a very very fine rug, where the fibers of the periosteum become the fibers of the capsule here, and the fibers of the capsule weave right back into the fibers of the periosteum, making a really nice, strong, tight connection. Another thing we see here, and I'll use blue this time, is to show you the synovial membrane, and that's that reddish pink line that you see. It's would be just deep to that articular capsule and surround the capsule itself, but note that synovial membrane does not cover the cartilage here. That's what we call articular cartilage, the cartilage we find at joints. If we're talking about a long bone, remember, kind of recall some of your knowledge. Where do we find hyaline cartilage? At the ends of long bones. So articular cartilage is just a phrase where we're identifying the location of the cartilage, but specifically in long bones, that articular cartilage is hyaline cartilage. So the synovial membrane does not cover that articular cartilage. It stops short of the hyaline cartilage. If we move over to the picture on the right, you see essentially what we saw on the left, but now the authors have added muscle and ligaments and tendons. So just for reference, here's the patella. That's your kneecap, so we know that that's the anterior side, and then on the other side, of course, that would be the posterior side. And you can see again the articular cartilage. That would be, I'll highlight that in blue here. So that's all that hyaline cartilage right there. And you've got more hyaline cartilage here. And then you see some ligaments. That's the patellar ligament. There's the quadriceps tendon. There's some ligaments here posteriorly that are a little bit more difficult to see. And there are also structures that we call bursae. So bursa is singular, bursae is plural. And the authors are pointing to these little green packets that you see here. And I'll explain those in a bit. Let's go on and learn about synovial fluid. Remember, this is the fluid that we find inside of joints. Depending on the joint, there's going to be more or less synovial fluid, and then the composition of this fluid tends to change a little bit as we age. But in general, synovial fluid has three main functions. It lubricates the joint. Synovial fluid is like an oil, and it's absorbed by the cartilage, by that articular cartilage, that hyaline cartilage. And so it makes the hyaline cartilage at the ends of long bones quite slippery and keeps them wet. So this prevents the surfaces of the articular cartilages from rubbing against one another. So I'll show you in a second, when we get to a better picture, I'll show you in a second again which cartilages these are. Think of synovial fluid as the oil you put in the engine of your car. The reason for the oil in the engine of your car is to prevent the moving parts from being damaged when the engine is turned on. So imagine your engine being completely drained of fluid, being drained of oil. Those moving parts might move for a few seconds until they grind to a stop because they get stuck on one another. And this is kind of the function that synovial fluid plays. We wouldn't want, as we walk around or go about our daily activities, those cartilages to be dry and rubbing on each other, because that's going to cause damage. And remember that all cartilage is avascular. So as an adult, you cannot repair cartilage because it doesn't have that blood supply. So the synovial fluid prevents those surfaces from rubbing on each other and causing damage. Also, on that same note, because hyaline cartilage is avascular, no blood supply, it has a difficult time carrying out exchange of nutrients and waste products. Normally, in many other areas of the body, blood is going to be brought to the tissue, and oxygen will diffuse out of the blood vessels, nutrients will diffuse out of blood vessels, and at the same time, waste products would diffuse back into the blood vessels. So you have this somewhat even exchange of nutrients and waste products. Well, because hyaline cartilage is avascular, the only way in which nutrient exchange and or gas exchange is going to be carried out is via diffusion, which is much less efficient. So the synovial fluid is carrying nutrients and removing waste products to those chondrocytes. And the way that this occurs is as you put pressure on a joint and release pressure on a joint, synovial fluid gets forced into the cartilage and squeezed out. The way I think of it is like a sponge. So imagine taking a sponge and getting it nice and wet, and then squeezing the water out of that sponge. That's similar to what happens to the hyaline cartilage when you put pressure on a joint. The pressure squeezes a little bit of the fluid out of that hyaline cartilage, and out comes with that fluid any waste products that have built up. And then as pressure is released from the joint, it's like taking that sponge and you're still squeezing it, right? You put it underneath the water and release the pressure. And what happens? New water flows into that sponge. Same thing happens with this hyaline cartilage. As pressure is released, new synovial fluid gets taken up into the hyaline cartilage with oxygen and nutrients. So while this isn't as fast or as effective as nourishing other tissues with vascularization, it does get the job done. These chondrocytes in cartilage have a really slow metabolism, but they're still living cells, so they still need to have nutrients brought to them and waste removed. They just don't require as much nutrients and oxygen and waste removal as other tissues. So that's why diffusion works in this case. And then lastly, synovial fluid acts as a shock absorber. This fluid doesn't compress. You don't need to really be concerned with the physics of it, but when pressure is put on the synovial fluid, it's distributed evenly. And so the fibers of the articular capsule, they're not elastic. The fluid doesn't compress. So when you take a step and you put pressure on that knee joint, the forces are distributed evenly, and it's the fluid that absorbs the shock. You don't have stretching of the capsule to accommodate that shock, and the fluid does not compress. That fluid absorbs that shock and distributes the pressure evenly. Let's have a look again at that same picture that shows you the sagittal section of the knee. And let me point out some things again for you. So I'll use black. Here's that articular cartilage in blue. And we want to make sure that as you use your joints that articular cartilage is not rubbing together. And then again, here's that the periosteum here, which then becomes the articular capsule here, and then again becomes periosteum here. This entire area in the center of the joint, or between those two joints, all of this would be filled with synovial fluid. So you can see how that synovial fluid is going to bathe that cartilage in its oiliness. Okay, so all of that would be synovial fluid. So where does synovial fluid come from? Well, it's made from the synovial membrane. And remember, that's this little pink line that we see right here. So that's going to be right inside that, or right deep to that articular capsule. But that synovial membrane does not cover the cartilage. Okay, so it's discontinuous inside of that articular capsule. And what synovial fluid is made of is, you don't really need to memorize this, I'm not going to test you on it, but it's made of hyaluronic acid and cells in the membrane. So let me just pretend, I'll just draw in some cells here. Let's imagine some cells making up the synovial membrane. Those cells in the synovial membrane are going to make that hyaluronic acid. And the way they do that is through pulling out some of the components of plasma. Plasma is the watery component of your blood. So the cells there kind of pull out some of that plasma from your blood and use those components to create hyaluronic acid, which is one of the components of synovial fluid. Remember, synovial fluid is oily. Another thing you'll find in that synovial fluid are phagocytic cells. So let's just imagine some basically macrophages in that joint capsule as well. And they're cruising around and they're looking for microorganisms or even cellular debris or any other type of debris. Maybe there's a little bit of damage to the cartilage here, right? And those phagocytic cells will go right to that and disassemble those chondrocytes that might be damaged, maybe a few collagen fibers. And so they're really kind of roving around inside there, making sure that that synovial fluid is as pristine as possible. As you age, you become a little bit more immobile. Some of us right now during COVID might be a whole lot more immobile than we normally would be. But regardless of the reason, age, or just not moving around as much, immobility causes this fluid to become thicker or more gel-like. So when you get up from the couch after having sat on the couch for some period of time, you'll feel this especially as you get older, that your joints are a little stiff. Or you hear your parents or your grandparents complain about their joints being stiff. So that really just refers to that synovial fluid being a little bit more gel-like and less viscous, more viscous. And then as you move around a little bit, that synovial fluid becomes less viscous or less gel-like, and it becomes easier to move around. So the kind of the old saying is, if you don't use it, you lose it, is absolutely true. If you think about it with bones, remember we were learning about how immobility or and in combination with estrogen dropping, that causes bone to start losing density, right? And the way that you can prevent the loss of bone density is through exercise, using that bone, right? And the same is true here with the synovial fluid. The more mobile you are, the more fluid-like this synovial fluid becomes. And the less mobile you are or the less you use it, it becomes more gel-like, okay? So we'll move on now to what we call accessory structures of the joint. And there are accessory structures that we find outside of the capsule. That's what extra means in this case, extra capsular structures. But there will also be intracapsular structures, those structures of the joint that are found inside the joint capsule. But we're going to learn about structures aiding the joint that are found outside the capsule first. So I mentioned earlier structures called bursae. Bursae is plural. So if we were to add an E on the end of here, that would make that plural, right? Bursa is singular. And a bursa is essentially a pocket of synovial fluid outside of the joint. So here's one. All these little green structures, these little pockets here, are bursae. And they develop through constant use of a joint. And their function is to cushion the rubbing of a tendon or ligament over tissues below, specifically osseous tissue. So let me erase that because I just kind of drew all over what I wanted to show you here. So here is, for instance, the patellar ligament, and then just deep to that patellar ligament, that's bone right there, right? So there's a little cushion of a bursa right here to prevent that direct rubbing of that tendon right on the bone. And there's another one here that is superficial to the patella, but deep to the skin. So this is going to prevent rubbing and friction of the skin on the patella itself. So inside of those bursae is synovial fluid, and it just acts as a cushion. They're very common in the shoulder and the knee joint, and as well as the elbow. Another accessory structure that we find outside of the capsule, an extracapsular structure, are tendons. Well, that makes sense, right? We know that tendons anchor muscle to bone, and where two bones come together is a joint. So, for instance, here's the quadriceps tendon, and the patellar ligament. I know it's called a ligament, and technically it is because it's anchoring bone to bone, patella to the tibia. But in this case, sometimes you might hear it called the patellar tendon also. I don't mind which one you use. The point is, though, what you see here is are tendons that help to stabilize the joint itself. So you have that quadriceps tendon coming down from the one of the muscles of the quadriceps group, and its collagen fibers are anchored to the patella. I'll draw that in green. And then coming from the patella are the fibers of the patellar ligament that weave right into the periosteum. So if I draw just a line here from the quadriceps muscle group to the tibia, if I could just show you one tendon, it's not, right? The patella is in the middle there. You've got this one dense connective tissue structure passing across the joint and helping to stabilize that joint. And you will also have tendons posteriorly as well, even though you can't see them in this picture, that are going to pass posteriorly from one bone to the next. So tendons are always going to pass across or around a joint. And they're used for stabilization and leverage. We'll talk about this when we get to muscles. But they also might inhibit movement. So it's kind of a trade-off between mobility and stability. The more mobile a joint is, the less stable it is. But the more stable a joint is, the less mobility there is. So always a trade-off. This tendon right here. And this is kind of a good example because we're going to move on to muscles here soon. I'll use blue. This is the biceps brachii muscle. Bi means two. Ceps means heads. So here you can see that there are two heads to this muscle, or that it's kind of split right here, right? And it has two tendons that are going to cross over the shoulder joint and anchor on different locations on the scapula. So you see how those tendons pass over the top of this shoulder joint and anteriorly here. So these two tendons are going to help stabilize that joint and but also allow for a movement. And you can see down here as well, at the distal end of the muscle, you've got tendons that are anchoring to the radius, and then this tendon right here would be anchoring to surrounding tissue, not necessarily a bone. But even those two tendons are crossing past this or over and around that elbow joint there. So now what we'll do is move on to structures that help the joints but are found on the inside. Intra means within. So in many joints there's going to be cartilage and fat pads. I would say every single joint has cartilage. Not all have fat pads, but there will be cartilage and fat pads. You can find cartilage, like I said, around any joint on the inside, but you don't always find fat pads. So fat pads are found around the knee joint or near a cartilaginous structure called the meniscus. I'll show you a picture of that in a second. And the function of fat pads and cartilage is to conform to the shape of bones at the joint. So these fat pads and these cartilages take on the same shape as the opposite bone, kind of like a hand fitting in a glove. They offer stability, cushioning, they restrict movement, and movement of synovial fluid. Let's go to... Okay, so we'll go back to here. Another structure or structures that we find inside of the joint are intracapsular ligaments. That's just a fancy way of saying a ligament that's inside the capsule. You find them in the knee and hip joints. They're meant to stabilize the joint, essentially holding the two bones together, right? The knees and hips are main joints that are carrying the weight of your body. So examples in the knee, for instance, are the anterior cruciate ligament and the posterior cruciate ligament. Let's have a picture here real quick. All right, let's look at the knee. I have torn a meniscus. Maybe some of you have torn a meniscus before, or even torn a ligament, but let me show you the shape of this meniscus. That's why I went to this slide, where here's the meniscus. It's kind of this figure 8 shaped structure right here. And you see how it conforms perfectly to the femoral condyles, these structures right here. Right here. So those condyles fit right in the space here created by that meniscus. And so that provides stability for the joint and helps prevent lateral movement in both directions. When somebody suffers a torn meniscus, usually it's caused by the tibia being planted on the ground and then some sort of rotational movement above, where that femur rotates or with too much force makes a lateral movement like this, or even a twisting motion, and then these condyles, let me erase some of this. And then what happens is these condyles right here, they slip over the top of the meniscus, and that frays the meniscus. And that causes damage. And that meniscus is made of cartilage, so it's not going to repair itself. The best thing that can happen is arthroscopic surgery. And what will happen is a doctor will take a little scope with a little cutting device on the end, and the doctor will kind of remove those torn bits of cartilage, and then we'll ask you to do rehab, strengthen the muscles here, the quadriceps muscle group here and surrounding muscles, so the muscles stabilize the joint even though you've lost some of that stabilizing cartilage. Let's go to our slide, and I'm going to erase some of these things because they're in the way. Okay, so The term cruciate, sounds horrible when I say it, is an adjective for the Latin root crux, which means crisscross. So here are your cruciate ligaments. There's the anterior cruciate ligament, which is this one, often referred to as the ACL. You may have torn this before. That often comes with a torn meniscus. And then posteriorly, behind that, let's use blue, crisscrossing it, but behind is the posterior cruciate ligament. Both of those are meant to stabilize the femur on top of the tibia, and also prevent these lateral movements from occurring. So it helps to laterally stabilize the joint, but also anteriorly and posteriorly stabilize the joint so that the femur doesn't move too far forward or too far backwards when you are carrying out your daily activities. Knee joint is a really important joint. If you think about all the weight that knee is holding, it's the majority of your body weight, right? So you've got a number of structures here that are going to help stabilize that joint, stabilize your body weight over the top of your skinny little tibia and fibula. Another place you find an intracapsular ligament, but you don't have two crisscrossing each other. One example would be here. You can't see the writing, and I don't think I've even asked you to learn it. But this ligament right here is called the ligamentum teres, and that's holding the head of the femur into the acetabulum, that fossa of the os coxa. So it's anchoring those two bones together. And then the last intracapsular structure I'd like to talk about is a labrum. Labrum means lip. That's singular for lip. Plural of lip would be labia. And what labia are little, almost like little cups of fibrocartilage. They are lips of fibrocartilage that help to deepen the fossa of a joint. Probably the best example to show you is on the hip right here. I'm just going to increase the size a little bit. So everything that you see in neon blue is part of that labrum. And that makes let's look at it over here too. It makes the acetabulum just a little bit deeper. So if I were to just outline the acetabulum here in green, it's pretty shallow, right? But if I use yellow, I can show you just how much more depth you get when you have a labrum there, and that helps to stabilize the head of the femur in that joint. Okay, so this is the end of the part 1 of the joints lecture, chapter 8. I will be putting together a part 2. Okay? That's all I've got for you.